It's a big pleasure for all of us at the IAGES family to meet all of you this evening for a very important event of IAGES, the IAGES Prime Time. IAGES Prime Time has been highlighting the legendary achievements and legendary work done by surgeons, both in the national and the international arena. So today we have two eminent personalities amidst us. One is Professor Michel Gagner from Montreal, and he is going to talk to us on minimal invasive endocrine surgery. And the next important personality is our own Professor Pradeep Chowbey, sir, who has been with us all through the IAGS and who has been our mentor and who has been our guiding force for all the IAGS activities and who has been there always with us. So to interview them, we have two most known and popular persons of the IAGS, and another than Professor Subhash Khanna, who will be interacting with Dr. Michel Gagner, and later our own friend, colleague, Dr. Deep, who will be interacting with Professor Chowbey. So this is the plan for the day. Now I take privilege and pleasure in inviting Professor Subhash Khanna. Professor Subhash Khanna is a very popular figure in IAGS. For people who are attending out of IAGS, a brief introduction about Dr. Khanna. Dr. Khanna is the past trustee of the IAGS, and he had a very long and glorious academic career on teaching side. And now he has founded his own super specialty medical institute in Guwahati, and he is the pioneering robotic surgeon from that part of the country. And in fact, to put credit to him, he was the one to initiate minimally invasive workshops and endoscopy workshops. And he conceptualized the advanced gastrointestinal endoscopy course, and he was the first to do the FAGI course in Guwahati. And he's a quite committed academician where he continues to train brilliant young surgeons to come into the field of laparoscopy and endoscopy together. Ladies and gentlemen, he also spearheaded the most important activity of the IAGS. The COVID relief program of the IAGS was spearheaded by our Khanna sir, and more so, the government of Assam entrusted him with the very big responsibility of handling more than 200 to 250 crores of rupees for distribution of the relief to the health sector. So he's a towering personality, and the most exciting thing I'm going to share with you is IAGS will be hosting the World Congress very soon, within a couple of years, and Khanna sir takes a very big responsibility in hosting the program for all of us. With that few words, now I would like to invite Professor Subhash Khanna sir to take over the day's proceeding. Khanna sir, over to you.
Thank you, Kanagavel. Thank you for that kind introduction. Good evening, Professor Michel. Good evening, Dr. Pradeep Chowbey, and good evening, everyone. My dear friends in IAGS, all surgical colleagues, and there are some invited guests also, ladies and gentlemen. This evening, I have the pleasant task of introducing one of the two legends we have today, and that the first legend to be introduced and who will be speaking to us today is Professor Michel Gagner. Professor Michel Gagner had a very illustrious career, and I consider him as a polymath, a man who knows many subjects. I shall be going through his short bio in few minutes, and let me introduce him. Professor Michel Gagner is a senior consultant at the Hospital de Sacré-Cœur, Montreal, and is also the chief of surgery at the Westmount Square Surgical Center, Westmount. He was born in 1960 in Montreal, Quebec, Canada. Dr. Gagner obtained a diploma in sciences at the Seminar de Sherbrooke in Sherbrooke in 1978. So he got his diploma at a young age of 18, and his MD from the Faculty de Medicine de University de Sherbrooke in Canada in 1982. He did his surgical training at McGill University in Montreal from 1982 to 1988. During his residency, he completed 2 years of PhD program on human lipolysis in sepsis at the Royal Victoria Hospital, McGill University from 84 to 86. Dr. Gagner also completed fellowships in hepatic surgery at Hôpital Villejuif in Paris, in France, and pancreatic surgery at Lahey Clinic Medical Center in Burlington at the Massachusetts from 89 to 90. Upon completion of his fellowship, he was recruited to the University of Medicine, Hotel de Montreal, where he was assistant professor of surgery from 1990 to 1995. He then spent several years at the Cleveland Clinic in Cleveland, where he founded the MIS Center in the year from 1995 to 1998. He was appointed the Franz Schizel Professor of Surgery and Director of MIS Center at the Mount Sinai School of Medicine in New York from 1998 to 2003. He later joined Weill Medical Center, Medical College of Cornell University, New York as Professor of Surgery and Chief of Section of Laparoscopic and Bariatric Surgery. He was until recently Chair of the Department of Surgery at the Mount Sinai Medical Center, Miami, and Professor of Surgery at Florida International University, and is currently Professor of Surgery at the Montreal. Dr. Gagner is known for his contribution in the field of minimal invasive surgery, in particular the first description of laparoscopic adenectomy for Cushing syndrome and pheochromocytoma. That was way back in 1992. First description of laparoscopic pancreatectomy, distal and proximal in 1992. First description of endoscopic neck surgery with parathyroid in 1995. First transgastric cholecystectomy or notes in 1997, and first description of laparoscopic donor switch for obesity in 1999, and laparoscopic sleeve gastrectomy in 2000. More recently, was co-surgeon for the World Transatlantic Robotic Cholecystectomy that was done between New York and the Strasbourg, France, and the only surgical article published in Nature in 2001. He has over 300 published journal articles, 40 book chapters, and 8 books on MIS. He has been visiting professor and operated in over 60 institutions in 48 countries. He has held prominent positions in more than 35 societies and organizations and has served on the board of 12 surgical journals. Dr. Gagner also has received a number of honorary memberships awards throughout his career. His most recent contributions focus on innovative upper digestive surgery, such as bariatric and endoruminal gastric procedures. That's, ladies and gentlemen, very brief of the huge amount of work done by Professor Michel. Ladies and gentlemen, a role model to be followed for all the young and all like us also for all the years to come. I request and I present before you, it's my pleasure to present before you Professor Michel Gagner for his talk. Professor Michel, please.
Thank you very much for this introduction. I'm very pleased with the invitation from the Indian friends and colleagues from the society. I think this is, as you know, I've been going and traveling over the years and enjoying my interaction with many colleagues present today, and I'm sure those that are also participating by the internet. So thank you very much for this invitation. So without any delay, I would like to share my screen and do this presentation because I have many slides. Many people know that I present too many slides, so I want to start right away. Let me share my screen. And this this should be full. So it's entitled Minimally Invasive Endocrine Surgery, 30 Years of Surgical Innovation, if you want. The first thing I would like to say is that a a lot of those discoveries have been by serendipity, which is a modern accident in modern medicine. This was discussed in 2007 in the New England Journal of Medicine. And in medicine, it is thought that 30 to 50% of scientific discoveries are indeed accidental and not happening according to the protocol. So surgery, I think, in laparoscopic surgery is in the same way. The discovery often starts when a researcher finds a bug in their experiment, of course, and you have to realize that maybe something is happening. For example, penicillin was discovered by serendipity because a mold had contaminated the culture. Of course, X-rays was discovered by serendipity because of the heavy paper that was put around to protect the X-rays. Well, that made an impression on the paper. And of course, more recently, Viagra was discovered by serendipity, increasing blood flow somewhere else. And, that led to Nobel Prize in Physiology in 1998, interestingly. So we have to reformulate sometime our, thinking to look at the bugs in the experiment and find that sometimes this is a happy accident. And of course, serendipity is a word that is difficult to translate. Recently in French, we have had this word, and in Spanish only a few years ago, serendipity, interestingly, comes from in a letter sent by the Earl of Orford, talking about a book, The Princes of Serendip. And Serendip is apparently Sri Lanka word for Sri Lanka. It's a Persian word for Sri Lanka, and where the apparently the tale of a lost camel, where the father is sending his three sons to look for a lost camel and a treasure, with indices along their journey. By serendipity, they discover the camel and the treasure. So I'm indebted to Professor Jacques Périssat from the University of Bordeaux, which had organized one of the very first World Congress of laparoscopic surgery, fantastic, with wine, and I believe in 1992, in the summer of 1992. But I had heard Professor Périssat in Toronto in 1989 during a World Congress of Surgery, presenting on laparoscopic cholecystectomy. And it's at that time that I believed that this would be the future of surgery for the next 30 years now. So laparoscopic adrenalectomy is the 4 topics I would like to cover. I started my career as a professor at the Hôtel Dieu of Montreal. This hospital is one of the first hospital in Canada. Was founded in 1642. It's in the used to be in the old Montreal, and at one point was one of the largest hospitals in the British Commonwealth. The surgical history described that the first nephrectomy was performed by Sir William Hingston at the Hôtel Dieu in 1868, but we're not sure if there was an adrenal gland as part of this resection, so it could have been the first adrenalectomy in 1868. And Sir William Hingston became later, as a surgeon, the mayor of the city, and was confronted to several pandemics of cholera at the time, which was without any treatment, of course, but nice surgeon who had made discoveries at the Hôtel Dieu. And Hôtel Dieu is also famous for Paul Cartier, a vascular surgeon who had done the first world axillofem bypass and fem-fem bypass, and was the one who was doing open adrenalectomy at the time when I came on staff in 1990. And I proposed that we do laparoscopic adrenalectomy. And he said to me, you have to show me how you do this in animals. And so we had established an animal lab and practiced laparoscopic adrenalectomy in pigs before 1992, make a video and show this to endocrinologists that it was probably possible to do this in humans. At the Bordeaux Congress, without knowing, Joe Peatland had presented a video on laparoscopic adrenalectomy. We had performed several cases, but of course did not had the opportunity to present an abstract on this. But Joe Peatland was among the first to do this in the United States with an anterior approach. We had we had submitted before. The presentation was in September, and this appeared in October, 1st of October, in the New England Journal of Medicine on laparoscopic adrenalectomy in Cushing syndrome and pheochromocytoma. So we had started to assemble a series at that time. We had done them before September 1992 and before Joe Peatland. I was unaware that in Japan, Higashihara and laparoscopic adrenalectomy in Japan. This was a report in Japanese from the University of Tokyo, from the urology, and this was in hyperaldosterone tumor. This is our press conference in 1992. You can see me on the extreme right, and Dr. Palm, for those who know, is the first person sitting there. We looked much younger 30 years ago, and this was of big interest. And my second fellow, Adrian Park, who became prominent also in the United States in the University of Maryland, had helped me published on laparoscopic adrenalectomy in the pig to teach surgeons, because it's one thing to do a procedure, you also have to teach it around the world how to do this. And we presented at American College of Surgeons 2 posters the following year, one on adrenal and the other one on double endoscopy, intraoperative ERCP for common bile duct stones was the problem of the hour at the time. And the president of the American Association of Endocrine Surgeons, Dr. Prinz, was present, saw our poster and asked me to do a presentation at the American Association of Endocrine Surgery. I presented on 25 cases in 1993. And of course, many audience, American endocrine surgeons were present and asked me to come to their hospital to perform their first laparoscopic adrenalectomy at the time. And I performed the first adrenalectomy at Yale University, invited by Barbara Kinder, and went from one institution to the next to teach surgeons how to do this operation. I went to the Mayo Clinic and helped them perform their first laparoscopic adrenalectomy. At the time, John Van Heerden, who was the prominent, one of the most prominent endocrine surgeon, was not a believer of laparoadrenalectomy. He tried to convince me to do posterior approach by an open incision, but it never took off. I think it stopped this progression with laparoscopic adrenalectomy. And the same with Charles Poix, who died a few years ago, was the most prominent international endocrine surgeon from Lille, France, had invited me to do 2 cases in his hospital, and was then convinced that this was the way to go. And then we published at the American Surgical on the first 100 cases in 1997, so 5 years later. And this was the American Surgical, is a very prominent association, and published in the Annals of Surgery in 1997. This was the stamp of approval of a technique. If we look from 1992 to 2002, so 10 years period, you see the number of publication increasing year after year, such that 10 years after the first adrenalectomy, there were 617 publications. And we collected 2,250 cases. And you can see the indication is just like any open adrenalectomy, aldosterone, pheochromocytoma, Cushing. Most of the surgeons at the time used the lateral transabdominal, which was my technique of putting the patient on the side. And 20% were using at the time retroperitoneal. This is the way we describe it, putting the patient on the side, flexing the table, putting trocars in the subcostal area, mobilizing the inferior part of the spleen and all the spleen ligament posteriorly to open everything like a book. And the left adrenal was sitting behind the spleen, and then dissecting the adrenal, isolating the vein and clipping this end, making sure that you're not damaging any renal vessels. The right side is a mirror image if you want, subcostal trocars, 3 or 4 in the subcostal right. The difference here is that it's a mobilization of the triangular ligament of the liver and exposing the cava. Here's an exposure live of the cava with a large vein that would not take clips. In those circumstances, when the vascular stapler came, it made the operation safer in handling a vein from the right on the right side. And then extraction is done with a bag, so you're not seeding in case there is a malignant tumor. You're not seeding in the tract of extraction. Getting the tumor in total with the specimen for proper pathological identification. You know, it made a stamp of approval with a very low mortality, very low morbidity. Complication within that morbidity was, number one, the bleeding. So you have to be very slow and careful. The reason for conversions, which are very low, was again because of bleeding or vessel injury. Now we progressed. When I was at the needle Cleveland Clinic, we progressed to do what we call needlescopic adrenalectomy, and that is the use of 2 millimeter or less instruments. And then the belly button was used for extraction, for clipping or observing, putting the laparoscope in the belly button, which is the, if you want, the precursor of a single incision laparoscopic surgery. And the needlescopic surgery started around that time, 94, 95. We started to have instrumentation, and we had experimented with needlescopic adrenalectomy, which was very nice cosmetically, and causing less pain and faster recovery. The hospital stay was reduced almost by 1 day using this. And then also we progressed. Instead of doing extraction from the belly button, we had extraction from natural orifice. That is from the stomach, making a small gastrotomy and taking the adrenal out from the mouth with a gastroscope, having just needlescopic instrumentation in the abdomen, or also vagina extraction. If I go to pancreas, we published in 1994, but our cases started before. I was a hepatobiliary surgeon doing, hundreds of cases of Whipple open. So I had the anatomy really in my head and started by using laparoscopy to make sure that the tumor was resectable. We were doing all the maneuvers, including looking behind the neck of the pancreas over the portal vein to see if there was resectable indeed. When we did those maneuvers, we were getting close to a resection. But the stapler came later, available in Canada more like the end of 1991, beginning of 1992. It was a short stapler, 30 millimeters long, and not the best, I can tell you. But it permitted us to do GI surgery. And so there are cases we did hand-assisted, but most of the cases we did completely laparoscopy. This is the first use of harmonic, because the first cases we did not have any harmonic technology. We had to transect the pancreas with the hook, for example, or the uncinate process with the hook. And so it was very cumbersome with primary instrumentation, and the needle drivers were the first generation to do all these hand-sewn intracorporal anastomosis. This is the dissection of the bile duct. This is the going in front of the vena cava, the portal vein. This is, we had to make ski needles by ourselves from curved needles to do hand-sewn pancreaticojejunostomy, and this is the beginning of the hepaticojejunostomy hand-sewn as well. Now, Cuschieri, who was the other one on the other side of the Atlantic, who started distal pancreatectomy, we believe we did first case before him, but he said there was no place for laparoscopic Whipple at the time because there was concerns for an oncologic adequate operation. So it made a stop on the development more than 25 years ago on laparoscopic Whipple. If we look at the first 10 years, there were only 146 cases. And the type of procedure were mostly laparoscopic classic. I was doing pylorus preserving Whipple at the time, so that constituted about 1/5 of the cases. And the tumors were mostly ampullary, periampullary tumors, or chronic pancreatitis. The pancreatic adenocarcinoma was 1/3 of those cases. Complications were 16%, but leaks were half of those complications, pancreatic leak present. You can see the operative time and hospital stay was not any different than open surgery. So it was the reason for the slow development. Oncologically, I think it was correct. The margins were correct. The lymph nodes were correct. And the patient behaved the same as an open operation. Now, I had the fellow Michael Kendrick, who came at Mount Sinai and got trained from the Mayo Clinic at my program, and then went back to Mayo Clinic and started to do laparoscopic Whipple. And you can see the laparoscopic Whipple performed in the Mayo Clinic, a very conservative institution, was the takeoff for laparoscopic Whipple all around the world. And I visited the institution with Michael being now the chief of general surgery. So that was very interesting and very thankful of him for his invitation. The message is that lap Whipple is feasible. The post-op period seems to be the same, but if it has no complication, the post-op recovery is even better than open surgery, and there might be some advantage oncologically, but we need some more large randomized studies to prove this. In terms of distal pancreatectomy, I think there's a stamp of approval. A very important paper we published in Surgery in 1996 was our experience with distal pancreatectomy and islet cell tumors. This was the largest series at the time, and we used French position. There are many techniques we describe: opening the lesser sac, doing distal pancreatectomy from the tip, or stapling from the middle and then going towards the tip of the spleen. We also identified and made videos on splenic preserving versus non-splenic preservation. So this is, again, the first generation of harmonics that you can see. Older generations of staplers, they got better. This is a technique where we transected the pancreas and going to the tip of the spleen, taking all the branches and preserving the vessels. And of course, you can do the reverse in many ways. Here's the harmonic taking down the parenchyma, the thick one, which cannot accept the stapler, and then closing this with sutures on the pancreatic duct. Laparoscopic enucleation, we started with hooks at the very beginning, and then we went with the harmonic to take out some islet cells and putting glue in the area. So if we look at 10 years of the first distal pancreatectomy enucleation, there was only 176 cases published with no mortality. This is very important, no mortality. The pancreatic fistula were 17%. And what made the stamp of approval for laparoscopic distal pancreatectomy was this, again, American surgical presentation of 667 cases where the open was compared to laparoscopic, and it showed no difference in positive margins, no difference in operative time, difference in leak rate, but it showed the difference in blood loss, hospital stay, and complication dramatically reduced by laparoscopy. So in conclusion, left pancreatectomies and enucleation are the way to go. They cause less morbidity and shorter hospital stay, and I think that has been approved. Then the endoscopic parathyroidectomy, which we published in British Journal of Surgery in 1996, the first one being in the Cleveland Clinic by the end of 1995 on a very complex cases. And then eventually the neck surgery expanded to thyroid and other pathology. At the same time, when we did these first cases in IRCAD Strasbourg to make demonstration, Micoli and Henri were there, Henri from Marseille and Micoli from Pisa. Then they went back in their own institution 1 or 2 years later to do their own technique. Our instrumentation was developed at the time and made for this type of surgery. We shorter ports, very tiny mini instrumentation of 1.5 2 millimeter. You can see these these that are even no longer available. And we had a 5 millimeter endoscope in the middle and just 1.7 millimeter instruments for dissection. These are among the first series, 64 parathyroidectomy at the time, mostly for single adenoma with operative time of 2 hours, which was twice or 3 times the time necessary to do this by an open technique. And as I said, Micoli came with a video-assisted technique. It requires at least 2 assistants to retract and hold the scope while the surgeon was dissecting, but it became easier and more popular. And the same with Henri in Marseille. This is my team in the mid-90s or end of 90s at Mount Sinai. Many of those fellows became leaders in their own field. Some you may recognize. And we started the program of the first endoscopic thyroidectomy in the United States and became very popular. We popularized needlescopic cervical surgery. This is the nerve, the recurrent nerve. It looks very huge by endoscopy. We make a lateral incision to extract lobes of the thyroid and make very cosmetic peeling procedures especially for women. Now, when those techniques were starting to be diffused and I was going around, Ogami from Japan saw us doing this and took a technique for the breast incision to do this kind of surgery. And of course, Takami from Japan doing an axilla technique very far to go to the neck. And this permitted the robotic to go from the axilla and eventually after that, the transoral technique. So to tell you how it goes into different evolution, our pig model permitted us to do carotid surgery in the neck, which never took off, but we were able to do suturing patches of Gore-Tex and doing all kinds of vessel surgery, esophagus surgery in the upper part, also in the neck. Here you can see a cricomyotomy being performed, and also cervical spine exposure and disc surgery in the neck. With that came physiologic studies of CO2 insufflated in the neck. We made boundaries of what was safe for human surgery, as well as intracranial pressure studies to make sure everything was good in the head while we were performing insufflating CO2 in the neck. And then lastly, the metabolic surgery development. Dr. Robino was a fellow that I had at the Cleveland Clinic and also at Mount Sinai. And we had protocols to look at hormones after Roux-en-Y gastric bypass, and also a protocol to look and study this in rats, which led to the development of duodenal bypass. At Mount Sinai, we developed a laparoscopic duodenal switch, and this was the first laparoscopic sleeve gastrectomy performed as part of the duodenal switch in July 1999. By serendipity, one of our patients could not get the intestinal part and got only the sleeve. And this led us to publish or present a first series of laparoscopic sleeve gastrectomy in 2000 for high-risk patients in 2 steps. And then the first presentation at an official meeting in SAGES 2002. So we know the rest is pretty much the history, that a sleeve is a removal of the left side of the stomach, leaving the lesser curve with a tube in place. That removes the fundus and body and lower lower half antrum. And now, in 2016 in the US, the statistics show that 3/4 of bariatric primary procedures are sleeve gastrectomy. So it has rapidly evolved. Randomized control trial with gastric bypass shows identical weight loss, remissions of diabetes are pretty equal, and hypertension, sleep apnea, not significant in this Swiss trial as much as the Finnish trial in the same JAMA randomized control trial publication of 2018 shows identical weight loss, not statistically different at 5 years. We think that this operation is good for Asian, low BMI for type 2 diabetes. This is a series from the China, shows that hemoglobin A1C is not any different than Roux in this series, and as well fasting blood glucose. So we think that sleeve gastrectomy has taken over the world as a first choice operation for diabetes as a metabolic operation. It's the most common metabolic operation right now in the world. And to move forward, I've made more research into duodenal switch operation, and we've made 4 consensus conferences. Duodenal switch is the best weight loss operation, but it's complex and has a lot of metabolic and complications. The resolution of type 2 diabetes has the highest ever. So how can we make this safe? That is really the question. And our 9-year data at Cornell of duodenal switch shows no diabetes 9 years later. And this is astounding when we think that we had 58% at the beginning of this series with the operation. So I went and did a series of sleeve gastrectomy with ileal transposition. We published this in 2005, and this was 2 years before De Paula in Brazil started to talk about this operation. We think that the interposition of ileum or the use of ileum is good for remission of type 2 diabetes because it changes some of the incretin. So we started in 2007 to do these duodenal ileal anastomosis. And this is what I call the duodenal bipartition, which is a side-to-side duodenal ileostomy. And I think that this operation will become probably one of the very common operations in the next decade. This can be added to a sleeve gastrectomy to complete the remission of type 2 diabetes. It's been very strong in animal data, and not only on weight, but on other. So the proper site of the ileum has to be determined, and will be part of the news in the future that you will hear from me. Because type 2 diabetes is more than 442 million worldwide that can benefit from this intervention. And it takes a long time to train a surgeon. So we need an intervention that is easy and fast for the treatment of our patients. So in conclusion, an idea has the right to be tested. We should get access to an animal lab to test those hypotheses. And I think it's important, what I've learned over 30 years is to get support from the colleagues and support from our boss so that we don't have problems when complications occur, because complication will occur in the process of innovation. And don't get discouraged in spite of negative comments, because I got a lot and I still get a lot today. And you have to be patient and persistent for establishing those findings. So thank you very much, and I apologize if I went over my time.
Thank you, Professor Michel. It was nice following your path to academic excellence all these years. There are a few questions, so maybe we have about 5 minutes or 10 minutes left. We can just request you to answer those. Maybe we would like to know what leads you to do such type of work, such innovative work. How it comes to you, and And what are you thinking about the future? What are your dreams? Are there any more things which you feel I have yet to do?
Yeah, I think it comes from poor satisfaction of existing procedures. I think I feel that we should never be happy with what we're doing. We should always think, how can I improve this procedure for the care of my patients? How can I improve to have better outcome, lower complications? So when laparoscopy started, we tried to make those open operations into a laparoscopic because we saw the benefit for gallbladder. And I said, well, if it's benefit for gallbladder, it can be a benefit for all the other operations. So that's how the cycle of these procedures were going from open to laparoscopic. Now that we've obtained a plateau, even robotic is not really improving the outcome of our patients because robotic is laparoscopic. Okay, so it's the same holes, same about the same time, and so the outcome is going to be the same. But the next step is, in my opinion, flexible endoscopy. So how can we make some of the laparoscopic procedures by flexible endoscopy? And that's going to be the next decade or two or three movement and miniaturize even more our instruments and do a combination of endo laparoscopy or endoscopic full. That's going to be the next, and I still have ideas to make this goal and make it so that the patient can even do procedures that do not require general anesthetic, that can go home the same day or a few hours after the intervention, and lower the risk of our connections by lowering the bleeding and the leak.
Thank you. I must share with you our association, IAGES, is running regular fellowship courses in endoscopy, fellowship courses in advanced endoscopy, which was started when I was a president in 2018. And we already are running these where we train up the young surgeons in therapeutic endoscopy also. So it's a now surgeons have realized, and we have taken that initiative. Very, very, very well said. Very well said.
Thank you.
So, any suggestions, any tips would you like to give to the young surgeons about how should they develop their surgery? Any tips from you? Because there are many young people will do the program today.
Yeah, you have an idea, you have something that you think would be good for the advancements of surgery. Don't get discouraged. Write it down, get access to a lab, try it, even if you have negative comments. At the beginning, many people were telling you, oh, it's not going to work. It's not going to work. Why are you wasting your time? No, do it and persist, because that's unless it's been really tested, you don't know. And you should, and it's surprising sometimes, even in the process of doing that, you find something new. And this is when you get into the development of new ideas and stuff.
Thank you. Thank you very much. There's the last question, the small question. Someone has asked Dr. BML Khadaria. He's of course from Nagaon. He wants to know, do you feel that the cost of treatment has increased, and even with minimal surgery of adrenal, thyroid, pancreas, we are able to satisfy your patients and we are able to satisfy our patients? Your comments, please.
Yeah, a few years ago, I established my own surgical center, and as such, you become an administrator and you discover and you know really what the prices of surgery is, and you know the cost of every instrumentation, drugs, disposable, etc., and you know the total price of a procedure. And I can tell you that out of the 10 most common procedure, there was only one that did not make this cost adjustment, and that was inguinal hernia. But the rest was cost sound by using minimally invasive techniques, because there is a cost to complications, and you have to take this into account. I believe that because the hospital stay is reduced, the number of morbidity and mortality eventually by the shift from even laparoscopy to endoscopy, will permit us to make a cost-effective thing. If we're going to treat obesity and if we're going to treat type 2 diabetes, and there are millions of people to be treated, if we can only do 0.5% of the entire pie, it's going to take us 200 years to do it at the rate that we're doing it. So we need to change what we're doing to make it shorter, faster, a faster recovery, and treat more patients by the same number of surgeons that we have available. So it requires a big shift in mentality on how to see these diseases and new procedures.
Thank you very much. I think I should hand over to our President Ramen Goel for offering a formal thanks to you, and once again thanks from me also, from all of us, for accepting our invitation and for sharing all your thoughts with us. Thanks.
Thank you.
Dr. Ramen Goel, please.
Thank you, Dr. Khanna. I think it's one of the happiest day of my presidentship to have two mentors here as the guests. So Michel, I have been in touch with him for last 20 years. I first saw him in Crete for the IFSO meeting, and I have been following his career and following him in different places, and had the opportunity to assist him in Coimbatore for when he did the first sleeve gastrectomy in India. And he has been to our center so many times and to India many times at various places to train us and to train various surgeons in bariatric surgery. That he looks so familiar. Anytime I have an issue, even with my own patient, I just send him a mail and he is back with a guidance and help. So that's great help, Michel. Thank you so much for being there always. And I realized that our paths crossed in Mayo Clinic. I was in 1992 with John Herden for about 2 months as a fellow visiting him, and probably we might have seen each other, but didn't know each other at that time. So it's really interesting that one surgeon who does a pioneering surgery is known by one surgery for rest of his life. And here we have a surgeon who pioneered so many surgeries. You can that I cannot even count how many procedures he has pioneered. And I am aware of the researches that he has done in many other fields, which ultimately I didn't come in limelight, but they were done. And he is in research in so many areas of general surgery, laparoscopic surgery, in almost the duration that we are in laparoscopic surgery, but he's in a different zone of finding new procedures and new approaches. And it's a great opportunity for us to hear from you, Michel. Thank you so much.
Thank you.
We hope we see you in India. You haven't come for a long time to visit us. And hopefully the COVID provides us a window later after we all are vaccinated sometime soon, that we see you in India with a new procedure or just be as our guest. Thank you so much.
Thank you.
Friends, the other guest is my second mentor, Professor Pradeep Chowbey. Professor Chowbey, who is Padam Shri Professor Chowbey, is well known to us. Our past president, trustee, chief editor of JMAS, and so many roles he has played in IAGES. And somebody whom I phone up, maybe 3 times a week. Whenever I have a problem or I want a solution, I call him up. And I can give you this thing that, I make him one phone call, and if he's busy, within 15, 20 minutes, he is going to call me back and giving me enough time to listen to the problem and give a solution. And he has been the guiding light on how surgical practice should be done in India. He has shown how the relationships are maintained between professionals, how associations are handled, and how you manage a team of surgical colleagues. I think most of the surgeons owe it to him of developing the first major surgical team in the country. And we keep asking him the secret of keeping them together. And so many times after a round of cocktails, he has shared a bit of the secret with us. But so I think that has helped create bonding between surgical teams all over the country. And so thank you so much, sir, for joining for this prime time. Uh, we have not kept a specific topic for you because we wanted to hear from you how surgeons should behave, how surgeons should take their careers, how young surgeons should think seriously about surgery. And I believe Deep Goel, who has been your student, is there to take you on that journey today. And we are delighted to have you, and thank you so much for joining us so late in the evening. But I am sure thousands of surgeons are online right now waiting to hear from you. Welcome, sir.
Thank you very much.
Over to Dr.
Thank you very much. Thank you very much, Raman. And I greatly admire and appreciate your leadership, and also so much of things you have been able to do with your team. Of course, our senior colleagues, Dr. Subhash and other colleagues are there. And amazing that we thought, I think that you have been able to lead IAGES from front, and we had much more interactive things happening and learning happening during this COVID period. And thank you very much for this great honor and your feelings for me and love and affection for me. Thank you very much.
Thank you. So may I request Dr. Kanagavel to please introduce Dr. Deep Goel.
Thank you, Dr. Michel, for this high wisdom talk, and quite inspiring. Like when laparoscopy was not existent, you went on to try both laparoscopy and endoscopy access for all the organs which are possible in the human body. It was quite inspiring. I'm sure that is going to inspire more younger surgeons to look into looking up and taking up avenues which have not been tried up. And I appreciate the important message which you left for the youngsters, that start doing something, even if there is a negative thought which has been flowing from your colleagues that may not work. That's the most important message the youngsters need now. Thank you so much for contributing towards the IAGES and the surgical fraternity of India. Thank you, sir. Now, I also thank Khanna sir for taking all the privilege, all the pains to prepare the important questions and brilliantly introducing the invited speaker and taking the questions at the end. Thank you, Khanna sir. Now, I have two important announcements before we move to the next topic. We have the next program of the IAGES Prime Time scheduled on 27th of December, the last Sunday of the year. We have two eminent personalities. One is an eminent Indian who went on to global eminence, none other than Professor C. Palanivelu, who was the founder of MASI and has been working with various types of multidexterous procedures. Our president, Dr. Ramen Goel, will be interacting with him. And we have yet another towering personality on the global arena, Professor Barry Salke. And we have none other than our past president, the most, mindful and thoughtful advisor and putting things in the right perspective. And he's going to shortly take up the most important responsibility of the president of the Association of Surgeons of India, none other than Professor Abhay Dalvi, who will be interacting with Professor Barry Salke. So we are going to close the year with a bang. So thank you, friends, for staying with us. And now I have the important responsibility of introducing our good friend, Dr. Deep Goel. Dr. Deep Goel has been a very illustrious student from Kasturba Medical College. He was the gold medalist. And later, he got trained at right places, Sir Gangaram Hospital, and went on to all the eminent places what Dr. Michel was telling shortly some time back. All his fellows were there in Mount Sinai, Cleveland, and most of the places where Dr. Gagner was telling, Deep has been trained for laparoscopic surgery and has been a very long and beloved student of Professor Pradeep Chowbey, sir. And right now, Dr. Goel is done a very important guideline on the obesity guideline during obesity surgery guideline during the COVID era for the Obesity Surgery Society of India, which was well received both in national and international arena. Dr. Goel right now is the senior and head of the minimally invasive and bariatric surgery divisions, as well as the surgical gastroenterology divisions of the BLK Hospital at New Delhi. And he has multiple responsibilities of various academic activities. To add feather to his cap is the most recent academic activity of the IAGES, the Indo-UK Surgicon, which was the well-received program where Dr. Deep was taking care of the scientific program. So let me have the privilege of inviting Dr. Deep to introduce Professor Chowbey formally and take over the program. Over to you, Dr. Goel.
Deep,
Kindly unmute yourself, sir.
Thank you, Dr. Kanagavel, for these kind words. And welcome, friends, to yet another episode of Prime Time. And today I am in conversation with the living legend, Dr. Pradeep Chowbey, Padma Awardee. As Dr. Ramen Goel has already introduced him, I would not waste time, but I would definitely like to say that he has touched many lives during his illustrious career. He has trained thousands of surgeons across the globe. For me, he is not only my mentor, he's a friend, philosopher, and guide. As Dr. Raman was saying, that I can reach out to him anytime during the day or night, and he's always available. He's a surgeon par excellence, teacher, a very generous human being. He has published extensively, and he has been office bearer of many, many international associations. With this, gentlemen, I am so glad to present to you Padma Shri Dr. Pradeep Chowbey. Welcome, sir. On behalf of IAGES and Docplexus, we extend a very warm welcome to you. And I would like to show a couple of photographs before I start. Can you recognize the young Pradeep Chowbey? One on the left side.
Okay.
Okay, this is a very cute family. His lovely wife, Susmita Madam, Abhinav, his son, Amisha, daughter. She's obviously my favorite. And now this young looking boy is already married to a very young, beautiful girl, has a child. So this is Dr. Pradeep Chowbey for you guys. Sir, the first thing which I would like to ask you is, thank you. The first question which I would like to ask you is, in your memory, what was the moment when you decided that you want to be a surgeon, or a thought crossed your mind that you want to become a surgeon?
Well, I think I would give that credit to my father, because he was also a surgeon, but not surgeon like us. He qualified from Madras Medical College in 1928, where there were very few MBBS doctors in the country. And of course, he used to operate cataracts and mastoids and tonsils and cesarean, whatever was possible in those days. And he was sought after a doctor, because not many government doctors were operating those days of chloroform and ether. So I think I had a great inspiration from him, because I saw that possibly he's respected much more than the other doctors because of his surgical expertise. And I thought that that may be a good profession for me to choose.
And when was this? Very young, or when you already entered the medical college?
Well, I think, no. I think it's much. When I was in the primary school, I have seen him going to the hospital. He always used to wear white dress and white shirt and white trousers, and he will change in the afternoon after doing the operations, and then will change to another white and go for his outpatient. So I think I had that image of a surgeon, and amount of respect which he got from each and everybody. And even the opinion makers, the bureaucrats used to be there, because he was the only surgeon in the district for that matter. So he was one of the very respected person from all the cadre of society.
Lovely. And you know, how did you decide and when did you decide that out of general surgery, because you were a very eminent general surgeon and a very busy general surgeon, and suddenly how did you decide that out of a big spectrum of general surgery, you would like to focus on a minimal invasive surgery? Because what I remember, even that time, the minimal invasive surgery was not even considered a subspecialty. It was just a, gallbladder was, and probably hernia. These were the two surgeries which were being done. So how did you take that gamble, and what made you decide and look into future that this is going to be a big subspecialty of general surgery?
Deep, I think at that time when this came, I was a surgical oncologist. I have trained in Memorial Sloan Kettering Cancer Hospital. I was there in Tata and Royal Marsden, also in London. So basically, I have been inclined towards the surgical oncology. And the biggest part which I never liked was the pain and the trouble with all these destructive surgeries the patients were going through. I did not really greatly appreciate that thing, but we had no option but to be very radical, very extensive in our approach. And that is when I was attending one of the congress in '89 in New Orleans, American College of Surgeons, where I was standing there. Reddy Carlson presented a couple of cases of what at that time was called video cholecystectomy. And he showed a glimpse of the patient walking a couple of hours after the operation, walking. And it was amazing. And I thought that this is the thing, this is the way I want my patients in the evening. And that's how it showed the seed of laparoscopic surgery. And of course, then I went to Dr. Mohan Shelappa in Singapore when he did the first laparoscopic workshop in '90. And that's how my journey started. I think I realized that surgeon, as being a surgeon, in spite of all our intentions of being very kind to them, looking forward for a cure for them from the diseases, we were possibly doing more damage because of just that incision. In the moment I thought that incision could be avoided and can be replaced by punctures, then I thought that was motivating. And of course, at that time, the Time magazine, the front cover I came across, which said the kind cuts of surgeons. So, because surgeons will never make a kind cut, but this was, of course, the kind cut of a surgeon, which was my big motivation to get into the laparoscopy.
And I think you created the first department of minimal invasive surgery in India, if I'm not wrong.
Yeah, actually, in fact, it was the first department of minimally invasive surgery in Asian subcontinent, and it was '96. And for this, I have always given credit to. I was conducting a workshop in Sri Lanka in Kandy in '95, and in the evening banquet, I met our mentor and legend, Dr. Udwadia, by the side of the swimming pool. And I said, sir, by that time we have conducted the first IAGES Congress in '95 in New Delhi. And I asked him, sir, what should we do now to promote this? And I said that I think if you can create a department of minimally invasive surgery, because he says, I made a mistake of not creating a department of gastrointestinal surgery way back a couple of decades back. And he always said that I always miss. And I think he said, Pradeep, you must try to make this department. And when I came back, another mentor, Dr. Sama, I expressed myself that I would like to do this. He says, it's your choice, but I'm sure you will be starving because I had a good general practice. And he says, just for simply a laparoscopic gallbladder surgery, why should you like to, in a private practice, give up other general surgical procedures which have bread and butter for that matter? But looking at my conviction, and he said, okay, go ahead. But my other two colleagues who were there at the time, who were a little senior to me, they said, we will continue doing laparoscopy and we will not stop doing it. I said, it's fine with me. I will continue. I think in the back of my mind, I would say that, like dating some is different, and getting married is different. So I thought that let me get married to minimal invasive surgery at that time, and so that I can possibly be more progressive in this direction. And then I think another important point was at that time when I thought of moving, my senior colleagues who are very senior, say for Dr. Kuller, who is with me for 35 years now, he was at that time I requested him, I would like to move. He says, I will join you. Dr. Anil Sharma, which is with me now 31 years, said, I will join you. And Deep, you were also there, and you moved out for your the Royal College. And Manish and Vanna, they were the registrar at that time, and they decided to be part of the unit of minimal invasive surgery, not really knowing that we were just doing all that at a time. But I think, this team which gave me the support, help, and of course, we always discuss. That is how I think we could create a department in 96, beginning of 96. And there was no such department in Asia Pacific region, because definitely the lot of general surgeons were doing laparoscopic surgery on a particular day of the week. Rest of the week, they were doing open surgery. But we decided, and that's why we started having a separate nursing and separate anesthetists for our department. And that's how I think in totality, we created exclusive department. And I feel after 35 years of our team, which for almost like 24 years of dedicated minimal invasive team, we are very proud today that we have covered a long distance and done almost about 85,000 surgeries during this period.
Seems Deep. Okay, he's there. Yeah.
Yeah, he's. Can you hear me, sir?
Deep, yes. Now we can hear you.
Can you hear me?
Yes, Deep.
Okay. Yeah, okay. So before I go to the next question, I would like to tell you a story that when I joined Dr. Pradeep Chowbey as a registrar, resident, our boss was Dr. K.C. Mittal, what he is mentioning, Dr. Chowbey, and he was a very hard taskmaster. And once my wife was talking to Mrs. Chowbey and telling her that Deep is so scared of Dr. K.C. Mittal, if he's sitting on the pot, and if the phone comes, he stands up from the pot. So Mrs. Chowbey started laughing, and she said, it is only Deep, not only Deep, it is also Pradeep, who is very scared. He also gets up from the pot. So that was the terror of Dr. K.C. Mittal, who did support him all along. So that brings us to the importance of what Dr. Raman was saying, that importance of team. When did you realize that team is so important? Again, the million question is, how are you able to keep all of them together even after 35 years? What is the trick? What is the charisma?
Well, I think there is no trick. I would say it's very simple. The trick is nothing else but we should learn how to live together, how to adjust each other in a way. Because I strongly believe that everybody is gifted. Everybody is gifted on this earth. Whether they are mentally gifted or physically gifted. The only thing is we have to realize and appreciate what they are good. So if you look at 5 of us, possibly you will see that 5 of us, all of us, we are different. Apart being competent surgeons, our inclination and interests are quite different. So I would say that as a leader of the team, first of all, I think whatever you are leading, so if it is a surgical team, you have to be a strong, a very good, competent surgeon who should lead the team from the front. And in times of crisis, you should not just run away. You have to face the music and you have to solve the problem because the buck stops with you. That is one. Another thing which I have seen that generally when you are leading, you don't create a space for other person. So when you climb a step, you should leave the next step for your younger colleague. So this is where you keep on climbing, and you let others also climb the stairs. You cannot just keep on climbing and let them be staring at you from the ground. So that is, I think it is important. You do whatever you want to do, give way to the youngsters, promote them. And of course, another mistake which we see many people do is that you want to take from the youngsters and not give anything. The leadership is possibly giving to your youngsters rather than taking from them. And you should take their wishes, and that keeps you going. I think in life, the most important fuel is the blessing of the elders and wishes of your colleagues, youngsters, patients, family, colleague, everybody. So this is the jet fuel. And if you can get that fuel filled in your tank, possibly that makes a success story. And I really feel very humbled and very proud and very grounded by the love and affection of my team and my youngsters and person like you and so many of our colleagues in India and outside India.
So in such a large career of yours, where you have seen your father from the previous generation, how do you think that surgical practice has changed in our country over the years? The kind of respect your father used to get, and what changes have you seen in the society and the practice at large?
Well, I think at those times, I think doctors were absolute God. I mean, there was no confusion. They were considered as God. They were honored as God. So I think there was nothing which I would say that was missing. And since then, and I'm sure we have seen now, is the voice clear?
Yes.
Okay. So even now you see, in last 2 or 3 decades, we have seen the difference, and what is the difference? I think a lot of distrust has come between the patient, their families, and the medical community and the hospitals. And this distrust is quite disturbing, which we actually, I'm sure many of us, we see the transition, and that's why in many of my presentations, I keep on telling our younger colleagues that you cannot sort of possibly consider yourself as God. I think your communication with the patient is very important. And if you communicate well with your patients and tell them about the condition, situations, the way you look at it, and the developments which are taking place, then I think you will still be respected in the present. And another thing which I feel is that because of the social media coming in, the negativity is very high. I think most of the negativity spread around the world is by social media, because you hardly get any good positive news. It always talks about your own achievement in life and how good you are and how well you are traveling and how rich you are and what cars which you are using, what food you are eating, what all cities we are going. I think that creates a lot of ambiguity about the relationship. But I feel that it is our responsibility as a medical personnel to create that aura around us and also be transparent, truthful to our patients and advise them well, which cannot and should not be challenged by anybody else.
I would agree, sir. I think to a large extent, even our community is responsible for this mistrust between doctors and patients, and it is our responsibility to take this challenge and lead by an example. And very rightly, you said that we have to be very transparent and genuine to our patient. So we often, as younger surgeons, younger colleagues, feel that a lot of our senior people who are famous, who are successful, they are there by luck. So there's always a fight going on between luck and hard work. What is your view about this?
Well, I think, Michel is also sitting here. I think thousands and thousands of persons were there at that time, like at any one of our time, I feel that opportunity knocks your door every day. Every day, some opportunity will come. And it all depends on you. As I said, we all human beings are very powerful. You have to realize yourself your strength. Opportunity will come and you have to grab that opportunity. And I'm talking of positivity in this matter, that you should not miss the opportunity. If you miss the opportunity, somebody else will grab it. And I'm sure all people who are sitting here on this meeting, I'm sure all of us at some time or the other will regret that why did we miss that opportunity. Of course, we are fortunate, our age group is fortunate that when this transition was taking place, we were at the right time of that transition. But at the same time, there were millions of people, millions of doctors who were there at the same time of opportunity. But maybe some doctors picked up that opportunity and utilized it for the betterment of the patients, for themselves. So in life, I think we have to think about creating a win-win situation. If you create a win-win situation for patient where he's benefited, you are benefited, the hospital is benefited, the community is benefited, there's some research, our other colleagues are benefited. I think, you should always think about creating. If you create a situation where you are the only winner, I don't think there will be, even if in the relation of husband, wife, son and daughter, child, your colleagues, you have to create a win-win situation. You cannot be the only winner. You have to have winners around you. That will sort of be the success story.
And as they say that luck favors the brave, luck favors the people who work hard. So as very rightly said, that opportunity knocks at our door every day. It is up to us how do we grab that opportunity. So when you look back at your lives, when you look back at the balance sheet of your life, do you have any regrets? Would you like to change anything?
Well, honestly, I don't think I would like to change anything in my this thing. I had no money. I had just about 50 rupees for Michel. I think it's less than almost like $50 in my pocket when I started my career. So I have no regrets. I was happy at that time also. What is important is your inner happiness, which is important. Money, fame, money, nothing gives you happiness. I think it's very transient and very temporary happiness. Somebody claps for you, you're happy at that time. But the moment you come down from the stage, there are many people who can you. So that doesn't give you, I think the inner happiness has to come from within. You should be admired by your family, your colleagues, your seniors, your youngsters. So that comes, that gives you the true happiness. So I would not really say that any regret in my life. And if honestly, barring one incident when Abhinav got injured in his eyes.
Right. So, when we talk about, you have operated so many VIP patients in your life, many presidents of the country, His Holiness Dalai Lama. Who has inspired you the most?
Well, I think without any doubt, I think His Holiness inspired me the most because of his compassion, because of his desire to make other person happy. And he told me many times, as you know, that I have a very close association with His Holiness Dalai Lama at a personal level, at a family level also. He invites the family, he invited my grandchild when he was 20 days old to bless him. So we are very distinct. But I think I would say that operating the President of India, operating big this thing, the protocol which I sent, I will just give a very simple example. When I operated President K.R. Narayan. He was sitting president, 83 years old with post-CABG, TIA, 11 medications, and he had a bad gallbladder, worst which can think of. But he did not, and there was a blue book protocol to operate a president that you should follow, and we had 76% attending that preparative meeting at Gangaram Hospital, and how to prepare. And I was chairing that session, and I said, we will do exactly the same what we have been doing for other patients for this laparoscopy cholecystectomy. And that's all. And that was one sentence. And the guys from judiciary, guys from Prime Minister's office, and guys from President House, they thought that we are going to do anything. And I said, if there is any questions, I will answer. Otherwise, we are not going to change anything. So that was one sentence which I said, that whatever is your patient, irrespective to the patient on the table is the God for you. There's no position, there's no post, there's no bank balance. So many industrialists we operate who have got, billions of their worth, but when they are on the table, you should treat them, do what you do for others. If you want to give a very good scar to a film star, you have to give the same beautiful scar to non-film stars also. I think even the lowest people would like a good scar. If you can't give them a good scar, you can't give a good scar to the person whom you want to. So it should be your habit to follow the protocols religiously as you do it for other person. And that is the only way you can avoid the so-called VIP syndrome. Most of the time you see and hear that VIP got this problem, that problem. It's only because you do a shortcut and you break that chain of confidence, and then things happen and they go wrong.
Right. So I remember during my training, you used to say that minimal invasive surgery is not only surgery, it is a philosophy. Would you like to talk about that? I think for a younger generation, that's an important message.
Well, I think when I started this surgery, and I always had shown, I'm sure you must have seen and our other colleagues must have seen, I've always shown a small bird in your hand. You can crush the bird. You can squeeze, you can do whatever you like, So I think we should treat our patients as a delicate bird or delicate creature. You can do whatever you like under anesthesia. You can do any surgery. You can connect any intestine from any part. You can cut any structure. You can divide. You can throw away anything, And the patient has given you that, and you should reciprocate that faith, confidence, which the patient has come to you. So I feel that kindness has to come in. So when the patient is saying that he's scared, we should console the patient. It's not that if the patient asks whether I should do this or that, for us, he's the thousands of patients, but for him, that is the first opportunity. And operation being a lifetime opportunity for most of the patients, we should be absolutely kind to them and make sure that we make them emotionally also comfortable as much as possible. So I've always talked, people talk about IQ and emotional quotient. I would always like to add the compassionate quotient for us and the love quotient for our patients. And once we follow that, everything falls in line. You will do the right procedure, you will advise the right procedure, you will handle the tissues delicately, which is the prime responsibility of a surgeon, and do the surgery which is necessary for that patient, however expensive or however small it may be. For the patient, the surgery is a lifetime experience.
Well, you have worked so hard throughout your life, throughout your career. What is your stress buster when you finish your work?
Well, of course, the biggest stress buster is the family because I always I'm always keen and I'm in a hurry to go back to the family. And once you reach to the family, I think you are distressed. But another thing our family has acquired is our appreciation in the field of art. And my son is an artist. He's studied in London College of Art, Royal College of Art. And my daughter looks after, has created India's first art bus app for the young artists. My wife has done masters in art. She is qualified. My daughter-in-law is a textile engineer and creative in designing. So I think that creativity keeps all of us bonded together. And of course, the music. My daughter plays piano. Amisha plays piano. Abhinav plays drums. So that is another part of our evenings, integral part of our evening. And of course, wherever we go out, we love to procure art, acquire art, sculptures, because Abhinav also makes sculptures. So I think and this is the biggest stress buster. At the same time, we have been fortunate enough to be in contact with the masters of the master artists and sculptors in India. And and I feel to maintain the sanity in your life, you have to do something beyond your profession, because your profession can make you sometimes insane and also give you a false sense, like a surgeon, it can give you a false sense of being God or, decision maker or, but it's not true. So to be grounded, to walk on the ground is the best way to sustain and be safe in your life. And this is our stress buster, the family travels together all over the world with a very keen interest to look around and look at the art. And of course, the enjoyment of shopping all over is interesting.
Yeah. Since we have Michel with us, Michel, would you like to ask anything specific to Dr. Chowbey?
Yes, I noticed that Pradeep, over the years we have met in different places, and he loved New York City. He came to New York City many times, visited Barry Sulky and myself. I think it was fortunate we were at the same place for several years. And I noticed that he became a president of IFSO. And this is a particular interest of me. I wanted to know how he became interested in obesity metabolic surgery and managed the political arena of IFSO.
Well, I think, it's very interesting. Now, Michel will, I don't think Michel knows about it, but I will tell, many of you will know. In 2000, there was a World Congress in Singapore, right? The World Congress of Endoscopic Surgery by Peter Grove. And I was at that time president of IAGES. And Michel, I've been interacting, Michel has been guiding me. I've been with Michel in, as I said, 94 in Perth, Elsa. I was the first time I listened to him and fell in love with him and his skill and his imagination. And then 96, we met in Singapore for microlaparoscopy. And then, we kept on meeting all across the globe. In 2000, just imagine in 2000, when I was president of IAGES, we were there, and I just read about, at that time I was interested because the pediatric, there was not much happening in the pediatric laparoscopy. So in one hall, I thought that there is a pediatric surgery going on, and I entered that hall, and Michel was talking about something like, taking the intestines from here and there, mixing up the intestines and joining. And I said, these looks adult intestines, and this is a pediatric hall, and what I am doing here, I thought that it's a pediatric hall. But then I realized, and I looked at, it's not pediatric, it's a bariatric. session going on, and I did not know what bariatric is. And when Michel finished, I asked him, what was it? Do you think in India we see all lean and thin person? But Michel said, Pradeep, you must get into bariatric. This is the future of laparoscopic surgery. And Michel, thanks to you, I got into that mode, and first thing I did was to visit you in New York, and you were kind enough to show us all sort of things. At that time, you were doing more BPD in Mount Sinai. Then you moved on to another hospital where we again went and learned from you. So I think this is what inspiration. Yes, I would say that I did not try to overcome this political arena, but by that time, I think we had a couple of friends who realized that we are transparent, honest person, non-political person. So they thought that for a change, we will make him a president. And there was 2 rounds of election in Hamburg, the World Congress. There were, elections, and the difference was less. And fortunately, I was, I think, very lucky and fortunate with, again, wishes and blessings and all of our friends and colleagues that they decided to elect me as a president of ISFE. That was the biggest honor in my life. And I had a non-controversial presidency, which we did without either anybody's favor or disfavor. We did what was right for the organization.
Thank you very much, sir. And just before I end this talk, what message would you like to give to the younger generation?
Well, I think the biggest message I would like to tell younger generation that you see all of us sitting here, it has not happened overnight. The younger generation, I see them banging their computers because it's not responding to their command. And well, I think I'm surprised. And like you are maybe 4G and 5G and you are the fastest computer available to you. But even if it is not working for a few seconds, you keep on banging and, calling all sort of 4-letter words. And that I think needs to be changed according to me. You have to have patience. You should wait for your stand in a queue. And COVID has taught us distancing. That is very important. You keep a distance. Don't sort of cross people. You have your passion. Do it passionately. Do it with heart. Increase your line rather than reducing others' line. Don't worry about what others are doing. Continue. Make yourself better today than yesterday, and even better tomorrow than what you are today. Keep the safety in mind. Safety is never enough. So whatever safe surgery and safe thing which we are talking today may not be true tomorrow. Maybe we have safer surgeons. So I think I would say that don't try to show off. Don't stick your neck out because then anybody can hit you and kill you. So I would say that just be grounded, wait for your turn, develop your surgical skills, be honest to your patients, tell them the correct advice. Don't give them random advice thinking. Think before you do anything, and be nice to your colleagues. Learn how to adopt with your senior, adjust with your senior, how to adjust with the younger colleagues, how to adjust with the administration. So I think it's a balancing act, and I would say the adjustment in life is very important, and balancing things in life is very important. And if you do it that way, don't get carried away by social media. Don't get carried away by the operations which are taught on the social media by 2 or 3 minutes video. We have to look both sides of the coin. Social media has got an advantage, and we should use it to our advantage rather than to do a fast track. Nothing comes easily, and you have to work hard. The more time you will spend with your patients and with your colleagues and other in the operation theater, the better you will be. So I would say that have your mentors, attend the congresses and learn from the seniors who will give you a very mature and time-honored advice, not on the fast track.
Sir, what an honor this has been talking to you, interacting with you today evening, and I'm sure thousands of surgeons will be benefited from your wisdom. And with this, I would thank you from the bottom of my heart personally, and I will hand over the mic to the office bearers now to thanking you officially. Thank you very much, sir.
Thank you, Deep. You have been very, very inquisitive, and I'm glad that you conducted this because you know the whole story behind the scene.
It's an honor, sir.
Thank you, Dr. Deep. I have got few questions from the platform also. So I would like to ask the same question to both the invited faculty today, to Chowbey sir and Michel sir. What do you think will be the most important breakthrough in the field of laparoscopy in the coming years? Dr. Chowbey first, and then we move on to Gagner.
Well, I think endoscopy, Michel, as I said, is key. These robotic things are coming, the miniaturization is taking place, but I think what still will remain the decision of doing what operation, and also possibly getting more and more focused on a particular subject and going in depth on that. A robot definitely takes away some of the handicaps, anatomical handicaps which human hands and the body have. But I'm sure if you see Michel operating, and I don't think Michel will be doing the surgery much better than even the robot. So I think it's a surgeon behind the robot which will control the robot's dexterity. And of course, as I said, it has got the advantage, but we have to look and see, and I think Michel will be able to tell us even more in this direction.
Dr. Michel, thank you, Dr. Chowbey sir. Michel sir, I would like to phrase this question in a different format to you. The pre-1980 surgeons, if they are capable of doing a good laparotomy, a good anastomosis, both intestinal and vascular, capable of doing thyroids and breast, they are good surgeons. But the 80s and 90s took a total revolution. It is not that you learn these fundamental procedures, you will be a good surgeon. You keep learning all through your career. So it becomes, you are not going to stop learning once you come out of your fellowship or your residency program. It is going to be an ongoing process. I'm sure, Dr. Michel, you've been learning, you've been trying so many things. I would like to know, what is your thought process of educating your residents and your trainees when you are already in the process of learning, and how do you handle this important together or parallel learning process, and how do you impart quality techniques when you yourself are learning?
Yes, I think new procedures go through a cycle of an idea, and then putting this on paper, putting a protocol, doing a research, and of course, wherever I had working in academic institutions, we had residents and fellows participating in those experiments. And then I encourage them to come in laboratory and do as much as they can to learn, because this learning process is helpful for human surgery. And then once the procedure is established in the animal and we have good outcomes, once we're happy with it, then comes the education cycle. Now, of course, we do it in humans, but after that we have to teach the community. So residents and fellows are important in participating in the research development, And after that, in the education process, they are part of it. They come and participate in human surgery, and then they're part of the team, and then they are part of the team of publication and presentation and videos, and it gets into the head of someone in different ways. And after that, when we teach, also to teach something, it has to be simple in your mind. If it's too complicated, you don't have the right message. So this whole cycle after that, when it's taught to the diffused to the surgeons in the community, benefits the whole patient locally and internationally after that. So the cycles restart when you have a new idea and you think that this would be improved. I think that all the medical students, residents, and fellows and surgeons in the community, they can participate in this whole cycle, and that's how I think everybody learns. So to think about what is next, of course, flexible endoscopy and flexible endoscopic devices, flexible robotics, not just rigid robotics, but flexible robotics. And of course, the two women who won the Nobel Prize for CRISPR. I think this will affect us as surgeons in a major way because we will start to correct genes, and then we will not have the same surgical targets in the near future.
Thank you, Dr. Gagner. And I think Dr. Subhash Khanna wanted to have a quick word with you. Khanna sir, going to be the organizing chairman of the World Congress in India. Please unmute yourself, sir.
Professor Michel, after several years of trying, finally India has got the World Congress, and I'm thankful to all the leaders, and Nathan Dundel, Barry Salke, and Alfred Kusheri were all there. We'll be doing the World Congress in 2024, and of course, before that, you are most likely to come to our annual conferences. But keep your dates blocked. I'll be sharing all the details. You must be our guest at that time during our annual conference. And it will be our annual conference plus the World Congress with IFSIS. So it's a formal invitation now.
Thank you.
Much in advance. Thank you.
Thank you.
Thank you, Dr. Khanna sir. Dr. Raman sir, you'd like to give closing comments before I hand over to the vote of thanks?
No, thank you so much. I think it was a learning process today. So many pearls of wisdom from both of them. You know, you even at this age, you feel that so much can be learned from people who have evolved from the ground and who have established a leadership, surgical leadership within the country and internationally. And I think the main thing, like Dr. Chowbey said, when you are operating on a VIP, do exactly what you do in a normal patient. These are important points that youngsters should get to learn, because all of us are going to face such patients, or we have faced such patients, and that opportunity knocks every door. Those who make the most of it move ahead in life, and others need to take those opportunities. And so I think Deep has done a wonderful job by asking probing questions with Dr. Chowbey and getting the right answers from him. So I think thank you all, Dr. Khanna, Dr. Deep Goel, Michel, of course. We look forward. I remember once you came to operate on my brother in Bombay Hospital. He came all the way only to do his bariatric surgery, and that was his birthday. And during the conversation, we realized, and we got a cake, and just two of us were there in the doctor's lounge and having a birthday cake with him, and his wife was on international call with him at that time. So there's so many memories of meeting Michel in different parts of the world. And of course, Dr. Chowbey is like a senior in my own home as such. You know, we are from Mathura. So thank you so much. And I would request Dr. Easwaramoorthy, who is the Honorary Secretary of IAGES, to propose a vote of thanks to our guests. Easwar?
Ishwar, sir.
Thank you, President. Friends, ladies and gentlemen, I think it has been a very wonderful, memorable day in the primetime calendar. I think I bring greetings from my President and all our EC, and to bring these two stalwarts, two great friends on the same day platform for IAGS. I think I should congratulate Subhasji. You've done a marvelous job to give us a Christmas tree. I think I'm sure Michel stands like a Rockefeller Christmas tree, standing tall as a truly, I think you are an innovative surgeon. I think motivating a lot of people in India. I'm sure you remember that, and you are welcome to our forthcoming thing, because I met you in Coimbatore when Bala brought you for the case, and I'm sure in May this next year we are going to have the 18th annual Congress. So you'll be there. Please book your flights, and we will be having you there. And I'm sure, Pradeep, every time you say you have revealed your secret, I think the secret of you is simplicity. I think that is way, and we have learned a lot beyond bariatric, beyond surgery from you, sir. You will be the guiding star for all of us here in IAGS. So as I said before, our 18th as an organizing secretary and also honorary secretary, I am on behalf of all the people here and all the international galaxies present here and also our stalwarts. Please come over to Coimbatore on this beautiful venue. I'm sure it's a safe place. By May, I'm sure things will be much get better with the vaccine around the corner. I think we have to be very positive to have the first on-site conference post-COVID. That's what we are trying to have on Lee Meridian on 6th to 9th May. Please be there. And in addition to the thing, we are going to have a colorful convocation. Michel, like to see, in spite of all the odds, I think our President Raman has done a wonderful thing trying to get the fellowship courses, training our youngsters, both in the arts of endoscopy, laparoscopy, and giving them a fellowship. And we are going to have a colorful convocation. This is going to be happening on the final day on a Sunday, and it will be really a treat to watch and in the midst of all the people and family. And this is a small announcement for the fellowship candidates. Please try to register. If you yet to become a fellow, try to register. There are only 2 weeks pending before you become eligible for this important thing. And as I said before, in order to encourage youngsters, postgraduate thesis award is also, we are recommending 1 lakh rupee. Of them is waiting, still 2 weeks to apply. And also I request all our researchers from IAGES members to also apply for this Best Researchers Award. So there's plenty to look for. Until that time, I say goodbye to IAGS. Stay safe, stay positive. Jai Hind, and a big thank you, big clap, and let us put together for 2 great personalities today assembled here, Michel Gagner and Pradeep Chowbey. Over to Kanagavel. You've done a wonderful job, and I think Docplexus also, I think they have done a wonderful job trying to share this to thousands of people across the globe. A great day to remember. Thank you. Over to Kanagavel.
Thank you, Dr. Easwar, sir, for sharing vital information and proposing the formal vote of thanks. And it is indeed a pleasure to host this evening program. And thanks to the President and the EC of the IAGES for allowing me to host this prime time. And it was pleasure interacting with the Professor Gagner, Professor Chowbey, sir, and our close friends of IAGES and mentors, Subhash Khanna, sir, and Deep Goel, sir. Thank you, friends. Thank you, friends, who have been taking part from India, from the regional Asia, and across the globe. Thank you, Docplexus, for giving a flawless platform. With that, we come to the end of this IAGES Prime Time. To remind you, we have 2 stalwarts coming up for the next IAGES Prime Time, Professor Barry Salki and Professor C. Palanivelu, sir. We look forward to yet another IAGES Prime Time. Thank you and good night.